The call came at 2:19 in the morning. Not to her work phone. That line had been disconnected from her account 6 weeks ago, along with her badge access and her parking permit and the email address that had carried her name at the end of it for 8 years. It came to her personal cell, from a number she did not recognize, and she answered it the way she had always answered unknown numbers after midnight, which was immediately and without ceremony, because 8 years of nursing had wired into her the understanding that unknown numbers after midnight were the category of call that required presence before information. The voice on the other end was a man's, and it was frightened in the specific way that people are frightened when they are watching someone else's body do something they cannot interpret, and the interpretation matters enormously, and there is no one else to call. He said he didn't know who else to try. He said his wife had told him once that if anything ever happened and she wasn't there, call the nurse. He said his wife's name, Ama Asante, had not heard that name spoken to her in 6 weeks, not since the morning the HR director had placed her credentials in an envelope and told her the decision was final. She closed her eyes for 1 second. Then she said, "Tell me what you're seeing." And she began, in the dark of her apartment at 2:19 in the morning, to save the life of the man who had ended her career. 8 years before the phone call, Ama Asante arrived at Whitmore Community Hospital for her first shift as a registered nurse with a BSN from Howard University. 2 years of clinical experience at a teaching hospital in Baltimore, and the specific quality of attention that her nursing school professors had identified in her second semester, and that one of them, a woman who had been practicing for 30 years, had described in her evaluation as the thing that separates a good nurse from a great one. She listens to the patient the way other nurses listen to the monitor. Ama had kept that evaluation. She kept it not out of vanity, but because it named something she had not yet found language for, and that she needed named, because the thing it described was also the thing that most consistently put her in conflict with environments that preferred their nurses to listen to the monitor and leave the interpretation to the physicians. She had grown up in Silver Spring, Maryland, the daughter of Ghanaian immigrants. Her father, a mathematics teacher, who had spent his career making precision feel like a form of care. Her mother, a seamstress whose attention to the integrity of a seam had always seemed to Ama like the same instinct expressed through different materials. She had known since she was 12 that she was going to work in medicine, not because of a single defining moment, but because of the accumulated evidence of her own attention, the way her mind naturally organized around questions of cause and what the cause produced in a body, and the way she felt in the presence of someone in pain, the specific pull of someone who has found the thing they are built for. Whitmore Community Hospital was not a prestigious institution. It was a mid-sized community hospital in a city whose demographics had shifted significantly over the prior decade, and whose patient population was largely working class, uninsured or underinsured. The kind of community that needed good nursing more than almost anything else the healthcare system could provide, and that, in Ama's experience, received it inconsistently. She had chosen Whitmore because of its patient population, and because it had an opening in the medical surgical unit that would allow her to develop the breadth of clinical experience she wanted before specializing, and because she was the daughter of people who had built their lives around showing up where they were needed rather than where they were comfortable. She was good from the first week, not the performed goodness of someone making a first impression, the substantive goodness of someone whose instincts were already calibrated and who required only the clinical environment to express them. She caught things, not dramatic catches, not the catches that end up in hospital newsletter stories about nurses who saved lives. The quieter catches, the ones that prevent the deterioration that would have required a dramatic save. A patient whose pain description was inconsistent with his stated history in a way that suggested a concurrent process the admitting diagnosis had not addressed. A medication interaction that the prescribing physician had not flagged. because the patient's chart at Whitmore did not yet reflect the medication she was taking at home. An early sign of sepsis in a post-surgical patient that presented subtly enough that the night shift had documented it as within normal variation, and that Alma, coming on in the morning, had looked at and known was not. She had been at Whitmore for 3 years when she was promoted to charge nurse. She had been at Whitmore for 5 years when the administration changed. The new chief administrative officer was named David Harmon. He was 55 years old and had come from a regional hospital system where he had built a reputation for operational efficiency in the specific sense that the term was used in healthcare administration in the early years of her career, which was the reduction of cost without the explicit reduction of quality, a distinction that in practice depended entirely on what you were willing to count as quality. He arrived at Whitmore with a consulting firm and a set of operational metrics, and a manner that communicated, clearly and without apology, that he had assessed the institution's inefficiencies before his first day and was prepared to address them. Alma noticed him the way she noticed systems, by watching what they produced rather than what they said they were doing. What David Harmon produced in his first 18 months was a series of operational changes whose cumulative effect on the nursing staff was the specific kind of erosion that happens when the conditions of professional practice are altered gradually enough that each change is individually defensible and collectively damaging. Staffing ratios adjusted. Documentation requirements increased while care time decreased. The incident reporting system that Alma had used as a tool for identifying patterns in patient outcomes was restructured in a way that made the patterns harder to extract. None of these changes were illegal. None of them were in isolation attributable to anything other than administrative judgment. Together they produced a unit that was demonstrably less capable of delivering the care that its patient population required. Alma brought data to her nursing director twice. The nursing director, a woman named Patricia who had spent 20 years at Whitmore and who was navigating her own complicated relationship with the new administration, received the data both times with genuine attention and insufficient result. Alma understood why. The nursing director was doing what was possible within the constraints of the moment, and those constraints were real. Alma also understood that understanding why someone could not act was not the same as accepting that action was unnecessary. She began writing things down more systematically. She had always documented. Her documentation practice was one of the things her supervisors had consistently identified as exemplary. But she began documenting with the additional intentionality of someone who has decided that the record is performing a function beyond the immediate clinical one. She documented the staffing configurations on the nights when incident rates were elevated. She documented the specific patient presentations that she assessed as having been affected by the resource constraints the new operational model had introduced. She documented the outcomes. The documentation was accurate, specific, and organized, because that was the only kind of documentation she knew how to produce. David Harmon called her into his office in the 22nd month of his tenure. She went with the data. He did not look at it. He told her she had a pattern of raising concerns through channels that were creating operational friction and affecting morale. He told her she needed to decide whether she was committed to the institution's direction or whether her interests were better served elsewhere. He said it in the careful language of a man who had learned to deliver these messages without creating documentation of his own, and she recognized the performance for what it was, and she told him she was committed to her patients, which was accurate, and which both of them understood was not the same as what he had asked. She was placed on a performance improvement plan 4 months later. The plan cited 3 incidents, each of which was a documented instance of her raising a patient safety concern through appropriate channels. The incidents were characterized in the PIP language in ways that inverted their nature. Her concern raising was framed as insubordination. her documentation of outcomes as undermining of institutional decision-making. The reframing was thorough, and she could see, reading it, that it had been prepared by someone who understood that the PIP was a document that created a record, and that the record being created was intended to serve a specific future purpose. The future purpose arrived 6 weeks later. On a Tuesday morning, David Harmon and the HR director sat across from her and told her that her employment was being terminated. The PIP documentation was cited. The decision was described as final. She placed her badge and her credentials in the envelope the HR director pushed across the table, and she walked out of Whitmore Community Hospital and drove to the parking lot of a pharmacy 3 blocks away and sat in her car for a while. She was not destroyed. She was clear-eyed, which was a different thing, and which required its own kind of sitting with. She understood what had happened. She understood its mechanics. She understood that she had been in a contest between the record she kept and the record they were building, and that theirs had been assembled with institutional resources, and hers had been assembled with a charge nurse's documentation discipline, and that this round had gone to theirs. She understood also that her record still existed, and that the question of what it was for had not been answered yet. She went home. She called her mother, who listened for a long time, and then said the thing her father used to say when a student couldn't see their way through a problem, which was, "The mathematics has not changed just because you are tired of looking at it." Amma sat with that. Then she made tea and opened her laptop and began to think about what came next. What she had not factored into her accounting of the situation was the patient she had cared for in the final month before the PIP. An 81-year-old woman named Cecile Harmon, who had been admitted for management of congestive heart failure complicated by a recent stroke, and whose care Amma had overseen with the particular attention she gave to patients whose clinical complexity placed them at the intersection of multiple failure risks. Cecile was sharp-minded and sardonic, and had opinions about her medication schedule that she expressed with the directness of a woman who had spent 8 decades earning the right not to soften what she thought. Amma had liked her immediately. She had also, in the course of managing Cecile's care, learned things that patients tell their nurses in the specific confidentiality of a clinical relationship, which is a form of trust as complete as any other, and more intimate than most. Cecile had talked about her family with the unself-conscious candor of an elderly person who has decided that time is too short for the performance of discretion. She had talked about her son. She had described him the way mothers describe their children. When love and worry have been occupying the same space for so long, they have become the same feeling, with a specificity that was not complaint, but something more complicated. She had told Amma that her son worked too hard and worried too much, and that he was the kind of man who managed external things with great competence and internal things with almost none, and that his heart had been making a sound lately that she did not like, because she had watched his father's heart make a similar sound before it stopped. Amma had listened the way she always listened, which was completely. She had noted the clinical implication of what Cecile was describing, a son with possible cardiac symptoms that had not been evaluated. She had, in the gentle way she approached such things, suggested to Cecile that she encourage her son to be seen. Cecile had said she would. She had also said that if anything ever happened to her before she could get him there, the nurse should know his name so someone sensible could help him. She told Amma her son's name. Her son's name was David Harmon. Amma had stood at Cecile Harmon's bedside and absorbed this information and felt the specific quality of a moment that contains more than it presents. She had not changed what she did. She had continued managing Cecile's care with the same thoroughness she brought to every patient, because the thoroughness was not contingent on the patient's relationship to her circumstances. She had noted it, and she had set it aside, and she had done her job. She had been terminated 3 weeks after Cecile Harmon was discharged. She had not, in the 6 weeks since, thought about David Harmon's cardiac symptoms. She had thought about many things, and that had not been one of them. It was not her information to think about. Cecile had told her in the context of a clinical relationship, and the clinical relationship had ended, and what Cecile had shared was Cecile's to share, and not Amma's to carry beyond the purpose for which it had been offered. Until 2:19 in the morning, when David Harmon's wife called because Cecile had told her son, before she died. She had died 4 weeks after discharge, quietly and not unexpectedly, and Amma had not known this, that if anything ever happened, and she wasn't there, call the nurse. And she had given him Amma's personal number, which Cecile had asked for on her last day at Whitmore, and which Amma had given her because patients asked, and she gave it because she could not imagine the reason not to. She talked him through it for 7 minutes before she was certain enough of the presentation to tell him what she was telling him. She told him his wife needed to call 911 immediately, that she was describing symptoms consistent with a cardiac event, that the call needed to happen now and not after any further conversation with her. He said he wasn't sure. He didn't want to overreact. She said call. There was a brief silence, and then she heard him relay the instruction to his wife, and heard his wife dial, and she stayed on the line until she heard the dispatch operator's voice on the other end, and knew the channel was open. Then she got dressed and drove to Whitmore Community Hospital. She did not go inside immediately. She sat in the parking lot in her car. The same parking lot. The same car. The parking space she had parked in for 8 years, and then not for 6 weeks. And she waited. She had called the emergency department to tell them the patient's name and approximate ETA and the symptom presentation, which she had done on the drive over, because that was the correct thing, and the correct thing was what she did, regardless of how the correct thing felt. The ED nurse who had taken the call had recognized her voice, had said her name, had said nothing else, because there was nothing else that needed saying in that moment. She went inside when she saw the ambulance arrive. She stayed near the waiting area, not announcing herself, not navigating toward the clinical space she no longer had access to. She was there because she needed to know he was in the system and being managed, and that the 7 minutes on the phone had been sufficient to the purpose, which was not her recognition, but his survival. She was there, the way she was always there, for the patient, which was the complete logic, and had always been the complete logic. The ED attending found her 40 minutes later. His name was Dr. Marcus Webb, and he had worked at Whitmore for 3 of the 8 years she had, and he looked at her in the way that colleagues look at each other, when the situation is something none of them have encountered in exactly this configuration. He said she had been right. STEMI. They were prepping for the cath lab. The 7-minute window she had opened with that call had been the difference between early intervention and a significantly more complicated presentation. He said, "Does he know you're here?" She said, "It doesn't matter." He said, "I think it does." She said, "Is he stable?" He said, "Yes." She said, "Then it doesn't matter." She went home. She had made tea by the time the sun came up, and she sat with it at the kitchen table and thought about the mathematics, which had not changed just because she was tired of looking at it. David Harmon was alive. She had participated in that outcome because a woman named Cecile had trusted her with information, and because she had answered a phone call at 2:19 in the morning, and because she had been trained by 8 years of work and a lifetime before it to hear what a frightened person was, describing and know what it meant. She had not done it for David Harmon. She had done it because it was the correct thing, and she was the person available to do it, and the correct thing did not consult her feelings about the person before it was required. David Harmon asked to see her the following afternoon through the hospital social worker who had been given her number by his wife, who had given it the same way Cecile had given her son Amma's number. Because Amma was the nurse, and the nurse was the person you called. She said she would come. She came. He was in a room on the cardiac floor. He was wearing a hospital gown and had the particular diminished quality of a man who has been on the other side of the clinical experience and who is finding the perspective instructive. He looked at her when she came in and did not say anything for a moment. His wife, a woman named Sandra who had the steady composure of someone who had been frightened and was managing the aftermath, stood near the window. He said, "You didn't have to come in last night." She said, "I know." He said, "You didn't have to stay." She said, "I didn't stay long." He said, "You called ahead for me." She said, "That's standard practice." He looked at her. He was assembling something and she could see him assembling it, the way she could see patients assembling things, the reordering of what they believed to be true against what the evidence was now suggesting. She did not help him. She had learned, in 8 years of nursing, that there were processes that could not be assisted, that required the person to arrive at the destination themselves or not at all, and that the nurse's job in those moments was to be present, without intervening. He said, "I want to talk about what happened." She said, "I know." He said, "I think I made decisions that I understood as administrative, and that were..." He stopped. He tried again. He said the PIP was constructed to produce a specific outcome, and the incidents cited in it were characterized in a way that did not reflect what actually occurred. He said he was not certain, in the management of his first year at Whitmore, that he had paid adequate attention to the information that was being brought to him about patient outcomes, and that the information that had been brought most consistently and most rigorously had come from her. He said he was telling her this not because it changed anything that had already happened, but because it was true, and he was the one who needed to say it. She listened with the same completeness she brought to everything. Then she said, "Your mother told me you worked too hard and worried too much." He looked at her. She said, "She told me about the sound your heart was making. She asked me to remember your name in case she wasn't there when it mattered. She was right that it would matter." He was quiet for a long time. Sandra, at the window, had turned away and was looking out at the hospital's courtyard with a careful posture of someone giving a moment its privacy. He said, "She was right about most things." Amma said, "She was a good patient. She knew what she needed and she asked for it, and she trusted the people she asked." He said, "She trusted you." Amma said, "She did." He said, "I didn't." She looked at him for a moment. Then she said, "You're going to need cardiac follow-up with a specialist. The ed attending can give you a referral. You should not wait on that." She said it in the tone she used for clinical instructions, which was clear and direct and not unkind, and he recognized the tone. She could see him recognize it. The tone of someone whose primary concern was the patient, and whose primary concern had always been the patient. She said she needed to go. She had an interview in the afternoon. He said, "Where?" She told him. It was a community health organization 2 miles from Whitmore, a federally qualified health center that served the same population Whitmore served, and that had reached out to her the week after her termination, because her name in the nursing community attached to a specific quality of practice that traveled faster than the paperwork of a performance improvement plan. He said, "They're lucky." She said, "I know." She left. She drove to the interview. She was offered the position before she left the building, which she had expected because she was who she was, and her record was her record, and the record that mattered was 8 years of caught deteriorations and documented outcomes, and a phone answered at 2:19 in the morning for the correct reason. She started at the community health center on a Monday. The patient population was her patient population. The people who needed good nursing more than almost anything, and who received it inconsistently, and who responded to its consistent delivery with a particular loyalty of people who have learned not to expect it and are being surprised. She was the same nurse she had always been, which was the nurse Cecile Harmon had called the sensible one, which was the nurse whose number she had asked for on her last day at Whitmore and put in her son's phone for the moment when it would matter. Whitmore Community Hospital underwent a governance review 6 months later, initiated by the State Health Department following a pattern of complaints that had been filed through a variety of channels over the prior 18 months, and that, when assembled by investigators with the authority to assemble them, told a story that the incident reports and nursing documentation and PIP files contained in fragments. The review resulted in a corrective action plan. David Harmon's contract was not renewed at the end of his term. He did not contest it. He had spent 6 months as a cardiac patient, and the specific instruction of that experience had altered his accounting in ways that he did not discuss publicly, and that people who worked near him felt as a change in what he was willing to hear. Alma's documentation, the records she had kept with the additional intentionality of someone building a record that might matter, was cited in the investigator's report as among the most complete and clinically specific of the evidence reviewed. She was not named in the report. She was described as a former charge nurse whose records demonstrated a pattern of concern-raising and outcome tracking that the institution had failed to act on appropriately. The description was accurate. She read it and thought about her father telling a student the mathematics had not changed just because they were tired of looking at it. And she thought that what the description meant was that the mathematics had eventually been looked at by someone with the standing to read what it said. She had 3 patients that afternoon. She saw each of them in turn, with the complete attention that was the thing she had always done first and would always do first, because the patient was the thing. Not the institution, not the record, though the record mattered. Not the outcome of the governance review, though the outcome mattered. The patient, this one, here, now, telling her what they were experiencing in the specific confidence of someone who had been told this nurse would listen and had found that it was true. She listened. She always listened. It was what she had been built for, and what no performance improvement plan, and no manila envelope, and no parking permit deactivation had ever reached. Because it was not in the badge, or the email address, or the access card. It was in the 8 years and the lifetime before them, and the woman at Howard who had written in an evaluation that she listened to the patient the way other nurses listened to the monitor. She listened. She documented. She called back the unknown number at 2:19 in the morning because that was what the moment required, and she was the person available to require it of. The mathematics had not changed. It never did.